Respected teachers, moderators, and distinguished and learned audience, good afternoon. I am Dr. Salim Mahmod, Chief Consultant, Dr. Shirajul Islam Medical College Hospital, presenting my topic, primary PCI. What are the best treatment options in acute ST-elevated myocardial infarction? We all know, according to all the guidelines, American College of Cardiology, European Society of Cardiology, it is the primary PCI and pharmacoinvasive PCI. It is class 1A indication if the patient present less than 12 hours duration, but in some cases, like if the patient has cardiogenic shock or heart failure, irrespective of time delay, we can do the primary PCI, and according to the ESC guideline, class 2A indication in a stable patient, we can do primary PCI 12 to 48 hours. So I am showing my first case, Mr. A, 60 years, presenting ST-elevated MI anterior with compressive chest pain for 5 hours. He is stable, blood pressure 100/60, pulse is 80 per minute, and I give the loading ticagrelor and aspirin. This is the ECG showing anterior MI. This is the right-sided angiogram showing distal critical lesion. And LAD was totally occluded from the proximal part, and it is soft plug. I did the wiring and straightforward stenting. It is a 10 minutes job. You can see the final results of this case, but in all the times, primary PCI is not straightforward. So case 2 is Mr. B, 53 years, presented with ST-elevated MI, with chest pain, sweating, vomiting, 2 hours, with cardiogenic shock, with complete heart block. His heart rate was 38, and he has a history of loss of consciousness towards back. His pulse was not recordable on presentation, and blood pressure was 60/40, and echo shows inferior hypokinesia with 42% ejection fraction. I gave prasugrel and aspirin loading. So this is the ECG showing 38 heart rate with complete heart block, and this is the right-sided ECG showing RB infraction. So this patient has 60/40 blood pressure, not recordable BP. Patient was presented 12:45 a.m. at night, and I gave the inotropes and TPM, and this is the left-sided ECG. Circumflex was critically blocked, not supporting the RCA. So right-sided RCA is occluded from the proximal segment. I did the wiring. There is a small thrombus in the proximal part. As the patient was hemodynamically unstable, I did a thrombus suction. I do the stenting directly. But that small thrombus was hanging in the proximal part of the stent. That's why I put a second stent, DES 316, covering the proximal thrombus hanging in the stent edge, and covering the ostium. I put the second stent. I did the post dilation with the same balloon pushing forwards and in the junction. And this is the final result of this case. And case 3, Mr. C, 59 years, presented with ST-elevated MI with ALBF with 4 hours chest pain. His blood pressure was 140/90 and pulse was 94. Ejection fraction was 34. Ticagrelor and aspirin loading given. This is the ECG. This is the echocardiography showing 34% ejection fraction. As the patient party was not agreed for primary PCI, they are taking time. I gave metal tenecteplase these patients, and in the next morning, I did the angiogram. So this is the lesion. So my first tenecteplase recanalization seen in there. So I did the ballooning with 210 mini track balloon at 12 to 16 atm. But there it is seen in the middle part, there is eccentric plaque. which is hard, not opening. So I took a bigger balloon to open, but my balloon was stuck in the middle slide. It is seen. My guide was going forwards. If I pull the balloon, my wire was going ups and downs, but balloon was hanging in the eccentric plug. I was sweating. At that time, I thought, what should I do? I rotate the balloon and short and steady jerky movement repeatedly. I finally able to remove the balloon. And in this time, I disengaged the guide wire from the left main ostium 2 or 3 centimeters away during the jerky push of this balloon. And now I tried. I don't have a scoring balloon at that time. This is an emergency procedure. So what should I do to cut this plug? So I took a second wire and an NC balloon bigger size to make it a scoring balloon-like action to cut the lesion. So you can see there is a second wire with a 2.75 10 NC balloon. And finally, I tried to negotiate the stent, but it was not crossing. And a repeated jerky push, I can able to negotiate the stent to the target side. And then I did the PD. Even after there is some part was not expanding, but final result was satisfactory. So my take-home message, primary PCI is not always straightforward. Patient may be hemodynamically unstable. Hello. The lesion may be acute or chronic. In that case, we should have all the facilities and hardware support to open the chronic lesion in an acute setting. So in an acute ST elevated MI patient, primary PCI is the best option to salvage the myocardium. Every patient should be evaluated from different angle to identify potential complications and should be managed promptly to save life. Small thrombus may remain hanging at the edge of the stent. To avoid this, little longer stent may help to avoid it. Lesion of ST elevated MI may be acute or chronic, so we should be well prepared with all supportive hardware to tackle this. We should be very careful when non-calcified vessels are severely diseased that is not giving support. So we should be well prepared during primary PCI.
Okay, thank you very much.
Thank you very much.
আমার মনে হয় আমার সবসময় হলো কি ডায়াসে যারা তারাই কথা বলতেছে, সো ফ্রন্টে যারা আছে তাদের তরফ থেকে কিছু শুনতে চাই, তারা কিছু অ্যাড করতে চান, কোনো কোশ্চেন আছে অথবা কমেন্ট আছে, এনিথিং ক্যান বি অ্যাডেড।
I have one question. What happened to the second case? With that patient came with heart block and you did it as primary PCI, right? After doing the PCI, primary PCI, how long, how after the patient came, the rhythm came back to normal or?
Just in the next morning, the rhythm is normal.
Day after that?
Yes.
আর কারো কিছু আছে? জামিল, শাহাব ভাই? No comment. Tamjid?
Yeah, actually the balloon stuck, third case, sorry about that. The balloon stuck in the middle, I believe. What was the reason? Was it an Oxford balloon, old balloon or something?
No, this is a new balloon. I never use Oxford balloon in primary PCI. And emergency cases, there is an eccentric plaque,
Was
hard
there some
plaque.
calcification visible on the fluoroscopy?
Sir?
Was there any calcification visible on fluoroscopy?
Yes, I can show you. You can see.
মানে ক্যালসিয়াম was there, তাই তো না?
Calcium was there, eccentric plaque.
আর কারো কিছু
You
আছে?
can see.
বলো, তাদের বলো।
আমি একটা প্রশ্ন করি, ওকে। What is your procedure of cutting wire system? Just put the wire and inflate the balloon or inflate the balloon and pull the wire back.
Sorry, sir.
What is the procedure of cutting wire system?
Cutting wire system. No, I just put body wire and I took a NC balloon. So one wire is outside the balloon. I inflate the NC balloon so that the extra wire cut the fibrous plug.
Did you pull it?
No, I didn't pull it. I just inflate the balloon.
You can pull it also. Yes. In the second case there was thrombus.
জামিল কিছু বলতে চায় নাকি? না স্যার, এদিকে আচ্ছা না হলে আমরা শেষ করে দিতে পারি আই থিঙ্ক সো তুমি যেটা বললা যে অ্যাকুট এমআইয়ের ক্ষেত্রে কিন্তু এই যে স্কোরিং বলুন কাটিং বেলুন ইউজ করা কিন্তু ডেঞ্জারাস দ্যাট মে পারফরেট উই হ্যাভ টু টেক কেয়ার অ্যাবাউট দ্যাটস অ্যান্ড মোস্ট অফ দ্য কেস ইউ ক্যান সলভ দ্য প্রবলেম বাই দ্য নন কমপ্লাইন্ট বেলুন গুড সাইজ নন কমপ্লাইন্ট বেলুন থ্যাংক ইউ ভেরি মাচ উই ক্যান গো
Sir, it is only I use when there is chronic lesion in acute setting. Acute MI,
chronic
but
lesion
lesion
acute
is
setting but
chronic.
you have to careful about that scoring and cutting
Thank you,
balloon
sir. Thank you, sir.
ওকে
Thank you,
প্রাইমারি
sir.
জাস্ট একটা আপনি ফার্স্ট কেস যেটাতে খুব স্ট্রেট ফরওয়ার্ড অ্যান্টিরিয়ামাই করলেন যেটা এখানে খুব ক্রিটিক্যাল রাইট কার্ডে ডিস্টাল অক্লুশন ছিল ওটা কিছু করছেন কিছু তখন সেম সিটিংয়ে
ওটা ডিস্টাল আরসিতে একটা টাইট লিশন ছিল।
হ্যাঁ
Yes, yes.
ফার্স্ট কেসটা
First case, it was direct stenting.
দ্যাটস ইট একদম রাইট কর্নারিতে
Right coronary তে
নন কালপ্রিট ক্রিটিক্যাল ব্লক
It is staged. I did it 3 weeks later.
anyway I think you can do it could have done it to the same sitting actually
opinion is different.
আজকাল
Somebody
অবশ্য এটা
in
evidence
favor,
বলছে যে
somebody in
আমরা same
disfavor.
sitting এ
So
করতে
thank
পারি।
you. I
Sir.
think so. Thank you for your presentation. We can last.
Thank you,
This
sir.
last presentation.
Thank you very much, sir.
Our next